Looking at the life cycle of erythrocytes, so because they don't have any DNA, they don't have any nucleus, they don't have RNA, there are no other organelles, they cannot replicate, they cannot divide or undergo mitosis. And so when they have traveled in the blood and they have transported oxygen, they usually just go to the spleen and are recycled or die. So they have a very short lifespan, about 120 days. And short, again, here, when we compare this to other cells in the body, like liver cell, kidney cell, that can sort of reproduce and renew themselves. And so we replace about 2 to 3 million red blood cells per second, or about 200 billion red blood cells per day. So very quick turnover when compared to some of our other cells. Erythrocytes are made or synthesized in the bone marrow via a process called erythropoiesis. And they die or are filtered through the spleen, and then some components can be sent to the liver to be recycled, okay? So they're pretty much made in the bone marrow, and then they die and are recycled in the spleen and liver. So looking further here at this process of erythropoiesis, it is stimulated by the protein erythropoietin, right? And erythropoietin is a hematopoietic growth factor. So it's basically what stimulates the new growth of erythrocytes. And this is secreted from the kidneys under the stimulus of low oxygen levels or low blood flow to the kidneys. So if you're not receiving enough blood flow through your body in general, and more specifically to the kidneys, this is a stimulus for the production of this erythropoietin from the kidneys, and then it can circulate, have an influence on the bone marrow such that we can differentiate those hematopoietic stem cells into reticulocytes and then into mature erythrocytes themselves. Now the differentiation is triggered again. The erythropoietin triggers the differentiation of those hematopoietic stem cells to reticulocytes at first, and reticulocytes actually still have their nucleus, they still have their organelles, but then eventually they further differentiate into mature erythrocytes where they lose that nucleus, they lose those organelles, mitochondria, everything, and they just start to produce hemoglobin, and they become mature red blood cells. The requirement for erythrocyte production, a couple of things are needed. So we need iron, obviously, right? It's the central component of hemoglobin, the heme part that we just illustrated there. And so the normal hemoglobin content of blood in men is going to be about 13 to 18 grams per deciliter. Again, slightly less in women for some obvious reasons, about 12 to 16 grams per deciliter. We also need some other things for that erythrocyte production. So folic acid and vitamin B12 are going to be important for DNA replication and then cell proliferation, okay? So we also need this for the cells to be able to differentiate into those fully mature erythrocytes and be able to start circulating that oxygen. Okay, this is why it's so important to supplement things like folic acid and vitamin B12 during pregnancy. So as we have the growth of that fetus, it's going to require a lot of cell proliferation, a lot of differentiation of those hematopoietic stem cells into various different cell lines within the blood. And so having folic acid, having B12 is vital. This is also why these things need to be supplemented if you're not getting them in the diet. So especially for vegetarians and vegans, these are two things that must be supplemented. Otherwise, we start to get things like anemia, where we don't have adequate red blood cell production. Okay, so let's talk a little bit about how they're removed. So that's how they're made. Let's talk about how they are removed or recycled. This happens in the spleen. So the spleen has macrophages, and macrophages are these kind of cells that can engulf particles. And so the spleen can filter these old, dead, dying, senescent erythrocytes and remove them from the blood. They can then be sent to the liver, so we can take that old, dying erythrocyte, we can plug out the heme part of that. We can take some components from there, send them to the liver where they can be recycled, either metabolized and broken down and excreted via feces or urine, or they can be recycled, right, specifically the iron part of that, and be reused to make new erythrocytes. Okay, so the spleen has these macrophages, kind of getting ahead of myself here. The macrophages within the spleen are able to engulf those old, dying, fragile red blood cells by a process called phagocytosis, which is basically just cell eating or cell engulfing. And then we can take that hemoglobin, remove the heme part of it, and separate that from the iron. The heme can be recycled by a bilirubin, and bilirubin is sort of a component of our excrement. It can be lost by a bile in the feces, and it can be lost in the urine as well, and we'll illustrate this a little bit later. And then the other component of that, hang on here, I'm seeing something in the chat. Okay, so I'm seeing a very interesting question in the chat, which I'll address here in a minute. And so the other components of that can be, again, secreted in the intestinal tract as feces, or then sent into the bloodstream through the kidneys and then excreted as urine. Okay, so that's how we can lose or catabolize that bilirubin component of hemoglobin. So someone is asking, what does it look like for a person who gets their spleen removed? And that's a really good question. This is why it's so vital. We don't have a way to lose those red blood cells. And so they have to be lost through the liver immediately, where this can also take place to a smaller extent, but that can create problems for red blood cell production, for new red blood cell production, because we don't have the ability to sort of recycle those vital components, such as hemoglobin, the heme part of that, and then the iron, which we can recycle. Yes, so someone is also asking here, does the liver take over? So yes, the liver can take over to a lesser extent, but the ability to repurpose, if you will, that hemoglobin is lost. And so this is why we can see anemia more frequently in persons who have lost their spleen. This is also why sickle cell patients have problems with the spleen. The spleen gets really enlarged, sometimes really painful, because the frequent turnover, so the turnover in sickle cell patients is even more rapid because of their, so in sickle cell, the shape of that biconcave erythrocyte is distorted. And so those cells die more quickly. And so they go to the spleen much faster. And so we start to see this congregation within the spleen leading to splenomegaly, which is a really large spleen because of the frequency of this loss of erythrocytes. Right? Some really interesting clinical correlations here. Okay, so let's sort of illustrate that. Oops. All right, so let's speak about what happens to iron. So iron, we said, can be recycled or repurposed to make new hemoglobin. So there are two forms by which we can do that. We can transport it bound to transferrin. This is called T-iron, and this goes from the GI tract back to the bone marrow or from the liver back to the bone marrow. We can also sort of just store it in the liver. If there's enough iron being circulated in the blood, we can sort of just store it up in the liver, and that is bound to ferritin, which is called F-iron, and we'll kind of illustrate that here coming up. So we can bind that iron to ferritin called F-iron, and we can just store that up for later use in organs like the liver, the spleen, and in some degree, the small intestines. So let's walk through this process of the erythrocyte lifespan, or the life cycle of an erythrocyte. So we said that erythrocytes are made via the bone marrow under the influence of erythropoietin, which is a hormone secreted in the kidneys. And so erythropoietin stimulates the differentiation of our hematopoietic stem cells into reticulocytes and then eventually into mature, fully formed erythrocytes where they've lost their nucleus, they've lost their other internal organelles, and they're really only adapted for this transportation of gases. After about 120 days, that erythrocyte is pretty much done with, right? So it's going to go to the spleen, it's going to get filtered out through those macrophages, and then we're going to grab the globin part off from the heme, right? So we're going to take the heme, which is the central part of that subunit, and we're going to separate it from the globin, or the globular protein component of hemoglobin. We can recycle the globin component because it's protein. We can just recycle it, repurpose those amino acids, and circulate them in the blood. And then we're going to take that heme component and we're going to further separate it into iron, which we can again repurpose, and then bilirubin, which we will excrete via the kidneys and the intestines. Oops. Oh no, what happened? Oh gosh, I apologize here. Okay. All right, so that bilirubin we said is going to go to the liver. From the liver, it's converted to bile. That bile can either be circulated in the blood, where it can go to the urine, where it can go to the kidneys and be excreted in the urine, or it can be lost in the gastrointestinal tract through the feces. The iron, however, the iron is vital. We can repurpose or reuse that iron. So we take the iron. If we've got enough iron circulating, if erythrocyte numbers are, good, then we can store that iron in the liver, in the spleen, or in the intestine, bound to ferritin in the form of F iron. If we need more iron, right, if we need more erythrocyte production, we can send that iron, now bound to transferritin or T iron, and we can circulate that into the blood, where it will eventually make its way all the way back to the bone marrow and be repurposed for a new erythrocyte, okay? And this flow chart is kind of all over the place. So I'll kind of just explain that again one more time here. So again, we take that old dying erythrocyte after 120 days, we split it into two components. The globular component, which is really the protein part of it, can be repurposed by converting it to amino acids. The heme component, which is really iron and bilirubin, can be circulated in the blood. The iron can either be stored in the liver, in the spleen as F iron, where it has ferritin bound to it, or if we need more erythrocyte production, it can be bound to transferritin, where it can circulate right through the blood, go all the way back to our bone marrow, and it can help with the synthesis of new erythrocytes. As far as the bilirubin component of that heme, it goes to the liver. It is converted to bile, and then from there, it will be then excreted through the small intestines or secreted into the blood, where it can be filtered through the kidneys and then again excreted via the urine. So there are two ways that we can lose bile through our system, either through the feces, through the GI tract, or through the kidneys via urine, okay? And then the really important take-home message here is that we can repurpose that heme, specifically the iron part of that heme, if needed, right? We can store it for later use, or we can circulate it for new erythrocyte production. All right, so this brings us to some clinical correlations here. So what happens if we don't have enough red blood cell production or red blood cell with the capacity to transport the gases effectively? This is called anemia. There are different types of anemia, as you would imagine, for different reasons along that lifespan or life cycle of an erythrocyte. So there's dietary anemia. This is if we're not getting enough iron or vitamin B12 in the diet. This is called pernicious anemia sometimes. And so as we would imagine, if we can't if you don't have enough iron coming in or vitamin B12 coming in, which is vital for the proliferation or the differentiation of those hematopoietic stem cells into fully formed erythrocytes, then we will have that deficiency in the amount of erythrocytes produced. Another type of anemia is called hemolytic anemia. This is usually due to malaria or sickle cell. And again, hemolytic anemia is if we have the disruption or the destruction of erythrocytes, which again happens usually in the spleen. So this is why I talked about that spleen being so important in sickle cell patients, in malaria patients, because of the misshapen form. And we can sort of see that here. So these erythrocytes are not their normal biconcave shape. They're misshapen or distorted. And so one, they can't carry oxygen as efficiently, but also two, they can get stuck in the spleen. They get stuck in the spleen, they get engulfed by those macrophages in the spleen more quickly than they would if they were normal functioning erythrocytes. In other words, the spleen thinks that all the erythrocytes are dead or dying. And so it just kind of filters most of them out and they kind of get clogged up in the spleen. Same thing with malaria. Malaria also has the ability to misshape or distort the shape of our biconcave erythrocytes. So that's that hemolytic anemia, if they're being destroyed at a faster rate that they can be produced. The other type of anemia here is aplastic anemia, and this is if we have a bone marrow deficit or bone marrow defect. This can be caused by a numerous reasons. So exposure to UV light, not UV light, exposure to different types of toxin exposure. It can also be the byproduct or the adverse effect of some medications, especially chemotherapy and other types of therapeutics can have an aplastic effect on the bone marrow. And essentially what happens here is the bone marrow cannot keep up with erythrocyte production. So there's just not enough production because of, again, toxin exposure or some type of adverse effect to chemotherapy, to some drugs, medications, etc. The fourth type of anemia here is renal anemia. So as you would imagine, when someone has kidney disease, especially chronic kidney disease, this hampers or dampens the ability of the kidneys to produce erythropoietin and therefore to stimulate that new red blood cell, new erythrocyte production, okay? And then the final type here is hemorrhagic anemia, which is pretty straightforward. If you're bleeding more than you can sustain that new erythrocyte, replenish those erythrocytes, then you will also see anemia here as well, right? So we can have not enough coming in the diet. They can be being destroyed at a faster rate than they are produced. They can be toxic exposure to the bone marrow that decreases their production. There can also be damage to the kidneys that decreases the erythropoietin production. And then we can just simply be losing erythrocytes, again, faster than they can be produced via bleeding of some sort, usually happening from trauma or some type of injury. Okay. All right, I'm going to pause here and see what questions we have so far. We've said quite a lot so far. And I kind of stumbled a little bit earlier. I forgot the exact term, but I think it's radiotherapy. There's some type of exposure that happens. I'm not quite sure what the name is, to be honest, but there's some type of radiotherapy exposure that can have a harmful effect on the bone marrow, especially for infants. So if infants are exposed to this type of toxin between that vital stage of, red blood cell differentiation, they can have a permanent damage on their ability to produce erythrocytes. Okay, so someone's asking for to repeat the definition of anemia. And so anemia is a loss in the ability of the oxygen carrying capacity of the blood, okay? Essentially a depletion in the number of fully functioning erythrocytes, okay? Someone else is asking about the difference between F iron and T iron. So F iron is that iron that's bound to ferritin, and that is the storage form of iron. So again, stored in the kidney, stored in the, stored in the liver, stored in the spleen or the intestine. And then T iron is the transported form of iron, right? Think about T for transportation. T iron is bound to transferritin, which is a form of iron that can be mobilized in the blood and recirculated to the bone marrow to be repurposed into new hemoglobin on new erythrocytes.